So I'm going to be talking to you about liver and the bariatric surgery. I'm going to obviously show you some pictures of livers, which is this one. So this is fairly large liver. Not sure whether it's just simple fatty liver, i.e. steatosis, or is it gone into NASH and is there any fibrosis? But technically it's doable. I mean, you can see the stomach down there. Technically, you probably would proceed and do the surgery. Similar situation, that's the stomach there. You can still do bariatric surgery on these people. The problem happens when you see this. I'm not sure whether I would like to proceed from a bariatric point of view in this person. To me, it looks as though it's a cirrhotic looking liver, and you really have to be a really brave person to actually proceed for bariatric input. So these are fairly simple questions to answer. Just to let you know, this particular person, did not have an abnormality in the liver function test. PT was 15, I think, as far as I remember, and albumin was in the lower side of normality. So before surgery, we didn't know what the condition of the liver was going to be. The big problem is, do we proceed here or not? Do we do something here or not? And what about this one? What about this one? So these are the questions we sometimes face when we actually do bariatric surgery. So what do we do? The question that we have to know is it simple NAFLD? If it is simple NAFLD, is it just fatty liver or steatosis? Has it moved on to NASH or steatohepatitis? Is there a fibrosis? And if there is a fibrosis, is it 5%, 10%, 20%, 30%? And if after bariatric surgery, I can actually reverse it. So the question is, can I reverse a 5% fibrosis and stop them going into cirrhosis? What about 30% fibrosis? Where we work in Sunderland, I think all of our patients actually underestimate how much they drink, including me. So really, could there be alcohol associated with what we call as non-alcoholic fatty liver disease? Finally, when you look at the liver and you think it's cirrhotic, should we proceed for bariatric surgery? Or should we do, what sort of surgery should we do? Should we do a bypass or should we do a sleeve? Moving on, sorry, the wrong way. So just to remind you, 25% of normal weight patients have NAFLD, because there are other reasons why you get NAFLD. But once you get to a body mass index of more than 30, nearly 90% of our patients would have elements of NAFLD. Now, when I say NAFLD, it's a broad category. It's very difficult for you or me to differentiate whether it's a simple fatty liver disease or is it gone into fibrosis and, God forbid, it's already cirrhotic. So just a few slides on, just to recap what happens with a simple fatty liver disease. To be honest, is a straightforward thing. If they lose weight, conventional methods or surgical methods, they will get better. Steatosis will get better. That's not a major issue. The problem happens when it moves on to so-called non-alcoholic steatohepatitis or NASH. Essentially what happens here is your macrophages and all sorts of leukocytes, they start getting into the fatty liver disease and actually cause inflammation. And sometimes our patients do present with right upper quadrant dull aching pain. The next step is the fibrosis. This is the interesting bit. How many of them actually progress to fibrosis is a big question. So what happens is you have your inflammation happening in your hepatocytes, you have this microcellular inflammation going on, and essentially healing starts happening, and therefore scarring happens. Eventually this scarring is going to spread, and therefore you would have fibrosis. Once that starts getting to a certain point, you would probably move to cirrhosis. Now that, between fibrosis and cirrhosis, it doesn't happen overnight. It tends to happen over 10 to 20 years. So therefore, people who you are operating for bariatric surgery, if you do see a cirrhotic looking liver, probably will fall in this age group. Now, when I looked at all our figures, the NAFLD essentially should be part of our metabolic syndrome in our NICE guidelines, and therefore should be included in metabolic surgery as well. Now, this is what it looks like. That's a normal looking hepatic parenchyma, the liver cells. Here you see the simple fat infiltration within the liver, and then here you see both infiltration with inflammatory cells along with some fibrosis that is starting here. What I don't know is if I stick a needle here and take a biopsy, it's going to give me a certain fibrosis score of 1 to 4. But the question is, if I stick the needle somewhere else, I may get a different fibrosis score. So this is what happens. What are the risks? Once you get NASH, risk of NASH moving on to cirrhosis is about 8 to 15%. And once you have cirrhosis, your chance of getting hepatocellular carcinoma or HCC is about 1 to 2%. In simple terms, once you have cirrhosis, 1% of people, 1 in 100, will go on to develop hepatocellular carcinoma. And also, just to let you know, nearly 5 to 10% of liver transplants nowadays are being done for NAFLD. So our hepatologists, how do they diagnose the fatty liver disease? Really, liver enzymes can be normal in 75% of cases, and actually they are quite insensitive in diagnosing NAFLD. I looked at AST and ALT ratio reversals. It is described by our hepatologists. It does matter. But when I looked at our figures, the ones that I had proven on histology that they have NASH, I didn't find that except in 30% of our patients who were diabetic. So the reversal actually happens in obese people with diabetes. I don't see it in the rest of the people. Now you can do ultrasound scan. It can probably tell you steatosis or fatty liver disease. It probably cannot tell you whether it's NASH or degree of fibrosis. CT scan, you need 30% of fibrosis happening before you actually pick up any scarring within it. MRI is probably more sensitive, about 5%. You would get 5% of fibrosis, and you probably would be able to pick up NASH or even the fibrosis. The difficulty is you cannot differentiate the aggressive NASH or the degree of fibrosis. In other words, you cannot turn around after doing an MRI or a CT scan and say this person has got 60%, 30%, 10% of fibrosis, and therefore it's very difficult to know. Now, fibroscan is something that's really useful. It is effective. It's good enough to use, and I think Sanjay, you mentioned that. What I would be interested to know, once you get a BMI more than 30, chances as your fibroscan is not very effective for actually giving you the impression of what level of NAFLD is going on here. So there are a lot of histological scoring systems that we I4 index, NAFLD fibrosis score, lots of scoring system, and the mere fact that they have so many scoring systems, basically it's difficult to actually get to it without taking a liver biopsy. And there are difficult, there is a difficulty, and the problem here is that diagnosing and prognosticating liver disease in patient is difficult with these scoring systems, and so, more so in our morbidly obese patients. Now, if you look at the non-invasive testing is reasonably accurate at excluding patients at extremes of fibrosis, fair enough. However, there's not a single test which is non-invasive which can actually tell you what is the degree of NASH or measure fibrosis. Now, one word of caution here. To get a proper fib score on histology, you need a very dedicated histopathologist. And there's a massive intervariability between reports. You can get scoring from 1 and the other one might turn out is 4. Therefore, you do need a very dedicated person. Second thing is, usually traditionally use a 16 gauge true cut needle, and the histopathologist, a good histopathologist, would want at least 6 biliary radicals to actually give you a fib score. And I mentioned to you, it depends where you stick the needle in. And actually, the European Association of Study into Liver do agree. They have accepted the fact the gold standard of diagnosing NASH or fibrosis or cirrhosis actually is taking a liver biopsies. Now, it's interesting that they do their liver biopsies percutaneously, and they do it in the right lobe. They don't seem to have many. When we are doing bariatric surgery, we have the liver right in front of us. We've got the left lobe, and we can stick a needle, and even if it bleeds, we can actually control it. So my suggestion would be that we do need to take more liver biopsies than we normally do. Now, just a few examples of a few studies, and there are loads on the literature, but I thought I'd just pick up a few of them. Neither BMI nor liver enzymes predict the presence of or the severity of NASH. And obviously, the next one is routine liver biopsies during bariatric operations is mandatory. And this is fairly old ones. These are 2009 reports. Now, the other one is intraoperative biopsy remains instrumental in diagnosing NASH. And there is no relationship between liver appearance and histopathological findings. This is something I find myself. And that's why I was asking that question. A normal looking liver, you may be taking a biopsy and you might actually find that there is a degree of steatosis or simple fatty liver going on in that. Here's another one. This is interesting. Again, it just turns around. It says it doesn't matter what your BMI is. Your NAFLD is completely different ball game. So what happens if we do bariatric surgery and does it reverse NAFLD? Again, a lot of new studies have come through, but one of the oldest meta-analysis, which is been published by Mumadi in 2008, probably stands the test of time. He looked at 15 studies. These are not the best studies. It's a very varied and haphazard paired liver biopsies taken in 766 patients. Majority cases were Roux-en-Y gastric bypasses, and essentially the duration between the liver biopsies was 2 and 11. Oops, sorry. 2 months and 111 months, and that's where the problem is. The variability is huge here. So this is what he finds. He found that simple fatty liver disease or steatosis is present in about 83% of cases. After surgery, after weight loss surgery, the resolution in steatosis or its improvement was seen in about 91% of cases. So simple fatty liver disease is not a big problem. The problem starts here. Steatohepatitis, once they get to NASH, he found 53% of patients preoperatively did have features of NASH, but improvement or resolution in steatohepatitis was seen in 81%, whereas complete resolution was only seen in 69% of cases. Going on to fibrosis. It was mentioned in 300 out of the 460 biopsies, which is about 65% of cases. The difficulty here is they did not classify what level of fibrosis was. Because at that time, we didn't have a kind of a recognized fibrosis score. Now we seem to have that, and our histopathologists have come to a consensus and agreement of giving a FIB1 to FIB4 scores, and I think we probably should look at that more closely. And what they said, once you get to a fibrosis, the improvement or resolution in fibrosis was in 65.5%. The difficulty here is we do not know what level of fibrosis was it. Was it 10%? Was it 30%? My assumption is probably 10% would be okay. What do you do if it's 30%? If it's 30%, what is going to happen? Are you going to push this person into cirrhosis, or are you going to have a patient who comes back to you 3 months, 6 months, 2 years, 5 years down the line with liver failure? And that's a difficulty. Now, this is a slide especially put in because there is a natural reluctance of taking liver biopsies. So I thought I'd give you a liver biopsy mortality. It's really, really low. It's 0.33%. And that too, that happens in people where you stick needles in hepatic malignancy, HCCs, and so on and so forth. And also remember, we are doing bariatric surgery. We can see the liver in front. We can see if it starts bleeding. We're also taking liver biopsies from the left lobe as opposed to the right lobe. If you do a percutaneous biopsy, as the hepatologists do, through the right lobe, your chance of actually hitting the big biliary radicals is much more higher, and therefore you may have a higher pile leak. So we have this unique ability of actually doing the liver biopsy quite safely and controlling any problems. And we may be able to turn around and say that we are preventing cirrhosis or we're preventing HCC by our bariatric surgical intervention. So these are some thoughts that I put in. It's difficult to, as we said, it's difficult to look at the liver intraoperatively and turn around and say it looks fibrotic. Probably cirrhotic is quite easy to point out. Now, what do you do? Do you get out, or what do you do? My suggestion would be, would you take a liver biopsy from the left lobe with a 16 French gauge, which is a standard advice given by a histopathologist. And they're going to go back and have a look at the fibrosis score, and then you have to take a decision whether you proceed and do the surgery. Now, obviously, I would withdraw in such cases and bring them back later on, have a discussion with the patient, give them the risks and benefit of surgical, and you need to weigh the risks and benefit of the surgical intervention. Certainly, if I can get them to lose weight, the NAFLD or fibrosis would be arrested or hopefully resolved. However, there is a higher mortality associated with it. Now, one of the things that I would recommend, or what I would think personally, is that I would actually do I want to know whether they have a reversal of portal flow. So I would actually do a Doppler scan on them to see whether they have portal hypertension. If they do have a reversal of portal flow, I would not do bariatric surgery, because then it's guaranteed this person is going to go into liver failure. What type of surgery? I don't know. I would probably do a sleeve. Any suggestions there? Anybody do bypasses in these people? So just a few things. When I said I'm going to bring them back, there are lots of criteria to decide which one you should operate. Certainly, class A, this is by far the commonest scoring system that we use. There are other ones like MELD and PELD, but this is by far the most common one used. And you go in and actually do a formal assessment, or your hepatologist can do that for you. And if it turns out that it's a class A, I would probably suggest come back, we'll do the surgery for you, depending on the liver biopsy as well. Child's B, I would be a bit more scared. Obviously, I want to be sure that everything has been turned out. I will definitely do a Doppler portal reversal of flow, and then have a frank and straightforward discussion of risk benefit of surgical intervention. If you're in child C, my suggestion would be, do not even think of bariatric surgery. The horse is bolted. And I would be very interested to know whether there's any other suggestions about that. So in conclusion, NAFLD is a common cause of chronic liver disease worldwide. It's under-recognized and it is under-diagnosed. We, as bariatric surgeons, have the ability of actually taking very safe liver biopsies, and we may be able to actually turn around and say we can prevent cirrhosis, cure fibrosis, or hopefully prevent future HCCs. It's a silent and slowly progressive disease. It is associated with significant comorbidities. And basically, bariatric surgery is effective in compensated cirrhosis without portal hypertension. And this is, again, when you see your patient is a completely asymptomatic patient, and you put your scope in and you find this cirrhotic liver, and you say, how is this guy managing? Basically, this person is compensated. And you do a simple, if this person gets pneumonia, or you do even a simple hernia, it is unknown. This person might go into decompensation. It's very difficult to know who is going to go into decompensation, purely because you have done some small little surgery, including hernias. And that's the difficult bit. And now we are deciding that in this person who is compensated at the moment, I'm going to do bariatric surgery, and I will definitely put them into a decompensated phase. And I did mention the portal flow. Cirrhosis with portal hypertension certainly is a contraindication for bariatric surgery, and I'm fairly strong in that opinion, though I'd be very keen to hear anybody suggest otherwise. It is preventable. There is no approved treatment yet available, though our hepatologists do have lots of medication. I'm not a hepatologist, so therefore I cannot comment on that. But at the moment, there is nothing that would actually change things apart from them losing weight. So from my point of view, NAFLD can be cured by weight loss surgery, though we've got to be very careful who we select for surgery. That's it.
Thank you, Shlok, for an exhaustive review. And I was going to go one step further. A small number of these patients are going to go on and have liver transplants in the future. And what do you think would be the view from the transplant surgeons about the impact of bariatric surgery in reducing the risks of subsequent liver transplant?
So we do get referrals sometimes from the liver transplant people, mainly from PBC point of view. I've never received any referral with cirrhotic looking liver, because usually the transplant people, they see the cirrhotic ones, they're already in child C. So we as bariatric surgeon probably never see those child C type of people. We probably see type compensated child A ones. So if a transplant surgeon turns around, look, I have time. If you can reduce this person's weight, his outcome is going to be better. His immunosuppressive medication would be much lower. And the patient and that surgeon and I agree that, look, it is risky, and I'll probably do a sleeve on them for two reasons. One is that you need a rule for them to create the transplants and stuff. And the other one is it is probably safer to do a sleeve. Does that answer the question?
That's fine. Thank you. Chandra.
Excellent on Shlok. I fully concur with you in all these aspects. Interestingly, I was the same news until recently, but interestingly, I was chairing the national symposium in LIBSS in Madrid along with Francis Paco. And we had one panel member from Seattle, a surgeon, who presented data on bariatric surgery in people with cirrhosis and portal hypertension. It was shocking because everybody said no, because for digital voting, everybody said no, we don't do that. Yeah. But then he showed his results. I'm carefully selected patient, but showed his results that it's doable. And I believe the 3 or 4 centers in America are doing this on, because they're 20 years ahead of us in bariatric surgery as such. And they're doing people with cirrhosis and portal hypertension. And that is a shocker to me.
Yeah. So Chandra, my answer to that is that you probably will get away with, I don't know, 10 patients.
This is, I'm listening what I...
No, I know.
What was the first time?
So my thought process is like any surgical intervention that we do, if we are kind of playing with the risk-benefit side of things, we probably, I would call it lucky, we might get away with 10 of them, but the one person is going to decompensate, and probably not decompensate tomorrow, is going to decompensate a few years down the line.
Okay, I think Sandy? Oh, Ashok? Yeah.
Oh yeah, thanks. I really enjoyed that talk. I think one of the issues, I think, again, why it's very difficult to make decisions is that we don't have the same kind of scientific evidence base as we did potentially for some of the older bariatric operations that did lead to liver failure and transplantation, such as gestational ileal bypass. And there were, if you look back at the literature from the 50s, from the 60s and 70s, they did routine liver biopsies, and all of those operations were shown to show a progression to steatosis, fibrosis, and then cirrhosis and liver failure. And I think we probably have comparatively less scientific evidence now. And even then, even with all of that, they still don't know whether it was protein calorie malabsorption or the bacterial endotoxin that was mediating these effects. So I think we do these kind of operations a bit blind if we're doing it in these more extreme group of patients that you're saying.
I mean, if you look at most of the world literature, including most of the bariatric units in the UK, the deaths that have happened usually are because of either malnutrition or liver failure. And we don't understand what is it that's protecting the liver. And you already have a liver which is not doing so well, and we kind of stress it to a point where it's going to go.
Sandeep? Yeah, and then, yeah. No, go on.
Just specifically on the concept form, do you itemize that you're going to do a liver biopsy sort of routinely if needed?
Yeah. So this is the debate I really wanted to have. Would you do a routine liver biopsy in normal-looking liver, considering the fact that even the normal liver may have a degree of steatosis? My thought process there, and that's my personal thought process, is actually you probably won't get much benefit out of it, because most of us actually do give them liver-reducing diet. You see, so I have a feeling that even if you do take a liver biopsy in what looks like a normal, non-blunted liver, it's got very thin edge and looks normal, I would probably not do a liver biopsy in that, because I don't think I would have any benefit of it, because even if it is steatosis or fatty liver, it's going to resolve anyway. So, but the ones that look dodgy, those ones I would have a discussion and take a decision, and usually child pays what child will be able to really think twice.
Thank you. One final question and then we'll move on.
An excellent talk. You covered a lot of points, but I disagree with some of the points you made. The first of all is the fibroscan, and there are enough studies to show that if you use an Excel probe with a particular CAP protocol, you can have a fairly reliable estimate of the degree of fibrosis in the liver. Okay, it may not be like accurate like F3 or F4. There may be an overlap, and that happens with biopsy as well. So even with the biopsy and an expert hepatopathologist, F3 and F4 are difficult to distinguish. So, we found the biopsy to be safe. Second is biopsy in a normal liver, looking liver. So in our 300 biopsies, the rate of cirrhosis was 5%. And some of them did not even look micronodular. So there can be an instances where liver may be looking, just fatty.
Can I interrupt you? You actually said cirrhosis or you said
Cirrhosis. Cirrhosis 5%.
5%
Cirrhosis, F4. Or it could be an overlap between F3 and F4. So that's point number 2.
Sorry.
So, and the biopsy is fairly safe. So what we do is we take a biopsy right at the beginning of the surgery, put the Nathanson, and really we don't even have to do any sort of hemostasis. So third point is about the cirrhosis. So in our center, based on our fibroscan findings, we counsel the patient. So supposing a liver stiffness measurement of more than 14 or 15, we tell them there is likely to be a bad liver intra, and so what do you want us to do? And all of them would want us to go ahead with surgery. And we routinely do a sleeve, and recently we analyzed the data of the F3 and F4 fibrosis group together. There's hardly a case of initial decompensation. Only one patient with that bad liver, the worst liver he showed.
Yeah.
So only one patient decompensated, not rest of them didn't decompensate. In fact, late decompensation is more common because all of them will not improve.
It's the late one.
So 80% will improve, 20% will progress. So you are benefiting 80% of patients. And I have a few cases, you'll be shocked to see how they have come out. Because there was no other option. Our gastroenterologist said they will die otherwise. And about portal hypertension. Again, I think it's child's A and low grade varices. And if you have counseled the patient about everything, I think there's enough data. Of course, I'm not saying so black and white, but
But this is why this is interesting. This is what we want to know, really.
Yeah.
So one thing is in NHS, fibroscan is not that common. We don't have it. I don't have or at least in our trust, we don't have the facility of actually doing the axial thing. I don't know. We have MRI. However, our MRI needs to be Tesla 7 or something. So hopefully we will get that, and that will be much more specific. I'm quite surprised that actually normal non-cirrhotic liver, you do a biopsy and it actually give you 5% cirrhosis. That is.
I'm not saying in normal livers alone 5% cirrhosis. I'm saying
Yeah.
overall cohort. Because if you look at, other series, again, the rate of cirrhosis varies from 3 to 5%.
Yeah.
So again, it's pretty high, and it may not be grossly nodular and not even micronodular. It could be just fibrotic.
Yeah.
And so I'm just saying that I think just to get more data and in a research setting. And in fact, now Oxford Group and some of the centers have all collected our data together, and maybe a publication may be coming soon on this.
Thank you. Thank you, Shlok. Thank you.